The probe has to push behind the posterior limit of the nodule. Okay, here my electrode is at inner and lower side of the nodule, so that means that I have to put one more superior. But again, at inner side of the nodule. So I change. Now you can see that I will not take the same anterior space. So I'm looking for the second one. Okay, I'm just here at the anterior of the liver. Okay, now I'm waiting to see again, but okay, I'm inside the nodule, the liver now. Okay, but I have just to wait, experitor. Okay. Okay. Third one. So the third one, according to the draw, third one will be this one, okay? The second one is here now. The third one, the first one is here, and I have to put to insert the third one here in this space.
Dr. Serro,
Yes.
Can you hear me? Can you hear me?
Yes.
Could you tell us what is the difference from the tumor margin to the first electrode? The distance between tumor margin and electrode.
Here I would say...
I mean, on the ultrasound, On the ultrasound, can you measure the distance between tumor margin, from tumor margin to the electrode?
Yes, I understand your question. We are supposed to have excavation
Okay, let me ask.
3 centimeters. And now I'm in parallel course. You can see that. That means that at the screen, the distance between the two electrodes is about 3 centimeters. So probably inside the liver, this is the same distance. Of course, I didn't measure.
I don't ask about the distance between two electrodes. My question is, what is the difference from the tumor margin to the first electrode? You inserted electrode just outside the tumor, right? Normal liver side. So my question is, what's the distance?
Okay. I will say here 1 centimeter.
1 centimeter.
I try to be insert the electrode at 1 centimeter from the edge of the nodule, because the nodule here is very small, about 18 millimeter. This is allow us to insert the electrode at 1 centimeter of the edge of the nodule. But now, if we are in situation with a larger nodule, I mean 3 centimeter or 4 centimeter, you can understand that in this situation we will have to insert electrode at very close to the edge of the nodule, without any distance You understand?
Okay, I see. Okay, let's go ahead.
Okay. Okay. You can. Okay. This is the third one. Okay. I insert it up that I feel the capsular plan. Okay? Again, we want margin. So this is my free needle. Now, inserted. I think we can start ablation. Perhaps you can have a view from this side. You can see what's happened here. I don't know. You see that? You see the arrangement of electrode? Okay? Okay.
Okay, very nice demo. But Professor Sehel, can you
Yes?
hear me?
Yes.
What is your criteria by using the 3, 4, or 5 or 6 probe?
With multipolar radiofrequency ablation, and this is mandatory. In fact, in most of cases, common indication, I mean up to 3 centimeters, you have to use 3 probes. This is clear. This is not possible to perform ablation with only 2 or and even more, only 1. And after that, if you are larger than 3 centimeters, I mean 4, 5, 6 and so on, rapidly you have to use 6 electrodes, rapidly. You understand? For common indication, I mean, in million criteria.
Next time you show the case with 6 probe to us.
Yes.
So I would like to the audience, particularly Professor David Liu, you also have many experience in the ablation of liver tumor, right? So in this case, did you have any other method by using a single or multiple probe or by microwave ablation? Professor David Liu.
We start? I don't know. You are ready? We can start the ablation or not? Okay, we start the ablation. We are starting now the ablation.
Okay, thank you.
Should I wait?
Okay, no. Please.
Yeah, so I'm not familiar with the bipolar, multipolar technique. I would think something like this at 1.8 centimeters, single, maybe 2 needles would suffice with the Q-tip type. Microwave, probably a single needle, and I would probably put it to the center of the lesion and leaving about a 1 centimeter different distance between this and the diaphragm. I think in my experience that will be sufficient to get the tumor and at the same time not do too much damage to the diaphragm.
You can see that. We start always. And the third one is very upper, is here. Okay? We are delayed.
Focus.
And the
Please.
tumor, the target is here, of course, in the cake. I hope so.
So how many minutes of operation in this case?
It could be about, I would say 20 minutes.
20 minutes.
Yes.
So long.
Not long.
Not long.
Not long. Why it's not long? Because you will see how much energy we are able to deliver in 20 minutes. And you will see that we will be around, 60, 100 kilojoules. And 100 kilojoules in 20 minutes is quick, is fast. In fact, this is quite fast.
So you don't need the manufacturer's instruction during the operation.
What?
Manufacturer's instruction guideline of ablation time.
No, I will show you what is the end point. You are, to know the end point depends on each patient and each tumor. And look at that now. We monitor electric parameters of the procedure with software.
Yeah, okay.
Could see that?
No.
This is really important. And the end point of the procedure will be based on this.
You mean the impedance?
Yes.
Impedance
yes.
and power.
Yes. And the curve, the inferior curve is the resistance monitoring.
Yeah.
Before operation, why not a CT scan?
And the superior curve
You mean
is
the
energy.
targeting
Is
is
energy.
is right?
CT scan to show the position of the
Okay.
probe. Why not?
I think that maybe the operator has confidence of his targeting is correct. Exactly.
This risk.
Okay.
This?
So if my feeling is that it's too low, I will increase the power of device. But according to what I see on ultrasound guidance, this is okay.
Okay, Professor Sehel.
Yes.
The one audience from the Professor Niu from China, she asked, why don't you use the CT scan for evaluation? Your targeting of the needle is correct or no?
Because it's not useful here. No? We can see that with ultrasound.
No need by CT scan confirmed.
But, okay. It's time consuming. I don't know why we are in a city room, but it was not planning like that. But okay. I think this is time consuming. This is radiating technique, and I think that in these cases, thanks to pleural effusion, we were able to see clearly the target, and you see online that it was possible to insert the electrode with ultrasound guidance very easily. So this is my opinion, this is my experience. Of course, we can use CT guidance, in fact, of course.
Okay.
But I think this is not completely mandatory. And I would add that it's not, you are not, and in my opinion, it's not sure that it's more precise. I prefer so much ultrasound for that.
Maybe this case is too simple for you. But I think for large tumor or for tumor with irregular shape, maybe if we like to achieve the complete ablation in one section, particularly after repeat insertion of the probe, maybe the last session we have to check the incomplete ablation or no by a CT scan or by contrast echo, right?
No. I think this is the wrong way. In fact, in the future, we have now I think CT is very interesting, in fact, but not online. I mean, not we can use fusion. In these cases, unfortunately for these cases, fusion was not able for these cases. But in my daily practice, for these cases, I use fusion. I mean, US with CT or MR pre-therapeutic. This is mandatory nowadays, for me, in my opinion. And in this way, you don't need, I think, to use real CT guidance. This is my opinion.
Okay, thank you. So is any question or comment or different opinion or major ablation for this tumor smaller than 2 centimeters? Professor Tanaka, for this case, you use 1 needle or 2 needle or 3 needle or by a microwave? I think we Asian country we have no reimbursed by government, so maybe we only use the 1 needle in this case.
You know, this is too low. You agree with me? We just now increase the power because I feel that it's too low, according to what I see on CT. Sorry, on ultrasound. So I increase about. We start at 60 watts, and now we are working at 90. Okay, so I want just accelerate the process.
The size of the tumor is less than 2 centimeters, 1.8.
And now it is faster. This is just a question of energy that we.
If the tumor is a very hypervascular tumor,
probably at the equilibrium point, the energy that we were able to deliver was dispersed by perfusion. So we working at 60 and it was not enough. I think for this patient, 19 is mandatory. We can see that on ultrasound.
But how many minutes of ablation now?
8 minutes.
8 minutes. But I see that the air bubble is not so enough. Even after 8 minutes ablation.
Yes, but okay. I decided to increase the power of generator. In fact, with a delay because I'm talking. I comment the procedure. In my daily practice, this action would be done earlier. Okay. You see that now?
We only see one spike.
No, look at that. You see?
Yeah, the gas bubble is increased now, but the impedance is only one spike now.
The impedance the impedance continues to decline. That means that that's really mean that I was my power output was not sufficient when I'm starting. But we cannot know. I prefer to start with low power and increase gradually. Because like that, I'm sure that I will deliver enough energy. Of course, this is perhaps more time consuming, but this is more safe.
Okay, but to my experience, I think this case the gas bubble is not so good fusion even after 9 minutes ablation. Did you think so?
Sorry.
I think the gas bubble is not so not so enough. Even after 9 minutes ablation. Yeah, to my experience.
It's not so good. You mean in terms of location?
Yeah. I mean in this case, the microbubble after 9 minute ablation is not so much and no fusion.
I'd like to ask the
Contrast injection? You are talking about contrast injection?
Actually, from my view, there is a fusion between the different electrode. And Olivier always say, please wait.
Yes, please wait.
I think the needle is about 5 centimeters in depth from the surface of the liver, about 5 centimeters of the depth. But the third needle, I don't know what the first or second, but the needle, the one of them too deep, and
You have to wait. Please. This is cooking.
Professor Lee, check the CT location of the needle.
Okay. Professor Seho.
Yes.
I think many audience concerned the microbubble is not so beautiful in this case. So can you check the CT scan of this case during operation? No. During operation now?
Yes.
Can you just stop and then check the CT scan of this 3 needle is the position is okay or no? Actually, we very trust you.
We will check after the end of the procedure if you want. Okay.
Okay.
We will check the CT scan after the procedure.
Okay. But before, I think before remove of the needle.
The needle will be placed within the liver.
Because it's very unusual, even after 10 minutes ablation, I think the microbubble gets the fusion not so not so good. Yeah.
Now there are 2. You see the 2 here. This is good. Now I have just confused with the third one.
Okay. So any question or comment?
So first of all,
How is 60?
so I think the tumor is located in difficult position.
Yes.
It's not very good indication for multipolar RF ablation. Because I think keeping equidistance between the electrode might be essential for getting uniform spherical shape coagulation zone with multiple RF ablation. So for the tumor located in very difficult position, I believe even with the multiple electrode approach, monopolar ablation would be more. I think it's easier than multipolar.
Of course, this is easier. You're right, but the purpose here is to achieve ablation with margin. So I totally agree with you. This is very difficult to answer here in such situation. 3 probes. This is clear, but I can assure you that in my daily practice, this is when I perform radiofrequency ablation, I use only this technique. I have no monopolar device in my department. That means that even for very difficult cases, I perform that. It's like for surgery. Some hepatectomy are difficult and some of them are not difficult. But all patients, when you have indication of hepatectomy, you have to go on it. independently to the difficulty. This is my opinion also.
I guess most audience in this room are using the monopolar ablation and also mainly radio frequency ablation. So why don't you have just take a vote? If you have this kind of patient, relatively difficult location, conspicuity is not so good. In that case, if you use the monopolar type RF electrode, how many of you will use 2 electrodes? Can you raise your hand? Needle number 2. Okay. Dr. Lu, you said 1 or 2, right? 2. How about 1, just single electrode? Single. Okay, how about 3 electrodes? 3. Okay, that's good. So roughly single 40, double 40, maybe 40 and 45. The minor part for the 3 electrodes.
You have a concern? No. It's okay.
Based on my experience, I think the 2 electrode adequate for this case because location is not so good. The conspicuity is also not fast. In that case, I think the 2 electrode will be adequate. Just in my opinion.
Close loop. I mean, the tube has to be plugged in the water bag.
In the case of multiple needle ablation,
also considering you have water.
the